Primary insomnia is a mechanical issue of behavior or environment. It is triggered by direct external variables, ambient light, noise, a poorly optimized mattress, or the shifting schedules of night work. Secondary insomnia is a neurophysiological consequence. The disruption is generated from within, driven by primary pathology. A common oversight is treating all poor sleep with primary interventions. Cognitive behavioral therapy deflects external triggers, but is completely ineffective against these internal lesions. These behavioral interventions fail in secondary insomnia because they target the bedroom environment, leaving the underlying organic or psychiatric disease completely unchecked. In these cases, the specific phenotypic presentation of sleep loss functions as a high-fidelity diagnostic biomarker, encoding the characteristics of the underlying disease within the sleep architecture itself. The exact architecture of a patient's sleep loss traces directly back to the source. Distinct perturbations correlate reliably with major depressive disorder, traumatic brain injury, or Lewy body dementia. Treating secondary sleep disruption uniformly masks the true underlying pathology. By ignoring the specific characteristics of the insomnia, the clinician loses a vital diagnostic signal and actively endangers the patient. This standard hypnogram maps the baseline of normal sleep. A healthy brain executes continuous 90-minute cycles, descending into deep NREM sleep, then ascending into REM phases. Pathological sleep latency occurs when this initial descent is delayed, requiring over 30 minutes to initiate sleep. Because the patient's wake time typically remains fixed by daytime obligations, this extended latency mechanically shortens the total overall sleep duration. This contrasts with early awakenings, where the patient wakes 1 to 3 hours before their biological baseline, permanently severing the final cycles of the night. Severe early awakenings are highly specific. They correlate heavily with major depressive disorder or underlying cerebrovascular disease. Beyond duration, we find structural failures, like slow-wave deficits. The brain completely bypasses the deepest N3 phases of NREM sleep, forcing the waveform into a shallow, superficial pattern. This loss of deep NREM sleep maps precisely to severe daytime impairments, primarily crippling deficits in memory consolidation and the inability to sustain cognitive concentration. Structural deficits in the sleep waveform predict distinct waking functional failures. The architecture of the insomnia identifies the disease profile. While slow-wave sleep restores cognitive function, the REM phase serves a different physiological necessity, the regulation of emotional processing. When the REM phase is restricted, the psychological consequences are immediate. Patients wake unrefreshed, highly irritable, and emotionally volatile, even if their total sleep time appears adequate. This deprivation triggers a neurobiological defense mechanism known as REM rebound. A brain starved of REM sleep aggressively and involuntarily attempts to initiate the phase during passive waking hours. If a patient is sitting idle or driving in traffic, the brain forces a microsleep to recover the lost cycle. This REM reduction and subsequent rebound effect present across a wide array of depressive and organic disease profiles. The brain's homeostatic drive to compensate for missing architectural phases cannot be ignored. It creates dangerous, uncontrollable physiological states throughout the day. During healthy REM cycles, the brainstem actively inhibits motor neurons, sending signals down the spinal cord to induce temporary muscle paralysis, a state called REM atonia. Without paralysis, the motor cortex physically executes the dream's actions. In REM sleep behavior disorder, or RBD, this inhibitory pathway is lesioned. Atonia fails, and neural signals flood the muscular system. Clinically, patients with RBD violently act out their dreams. They will shout, punch, or attempt to flee while fully asleep, posing a physical danger to themselves and their partners. This specific disorder serves as a paramount diagnostic marker. Its presence strongly indicates Lewy body dementia or Parkinsonism, distinguishing these conditions from standard Alzheimer's disease. But there is a severe iatrogenic risk. Specific antidepressants chemically alter REM architecture and can artificially induce this exact state of atonia failure. This chart illustrates the pharmacological risk gradient for inducing atonia failure. Venlafaxine carries the highest risk, stepping down through fluoxetine, sertraline, paroxetine, and chlorameptine. Bupropion and agomelatine sit in the lowest risk zone. Applying pharmacological intervention without precise phenotypic profiling can iatrogenically mimic or actively induce the symptoms of severe neurodegeneration. Expanding our view, this circular activity clock charts the overarching 24-hour circadian rhythm, moving beyond the 90-minute microarchitecture. Structural disruptions to this macro clock point away from primary psychiatric conditions, strongly indicating physical organic brain diseases like traumatic brain injury and neurodegeneration. In a sleep inversion, total sleep duration remains intact, but the cycle flips. The patient is alert at night and deeply asleep during the day. A phase delay maintains the block's length but shifts it later. The biological sleep drive doesn't initiate until 3 a.m. This creates a very dangerous clinical trap. A patient with a phase delay will complain of an inability to fall asleep at night, leading to a misdiagnosis of standard sleep onset insomnia. Prescribing a standard hypnotic in this scenario chemically forces sleep while the biological clock is still actively signaling wakefulness. This chemical clash destroys the sleep architecture. The drug wears off prematurely, the patient wakes early, and the temporal structure completely desynchronizes. Misinterpreting a circadian phase shift as simple insomnia leads to interventions that chemically aggravate the patient's existing pathology. We must also separate common frequent awakenings from the much more severe pathology of true fragmentation. Frequent awakenings are brief, transient interruptions within a single continuous sleep architecture. This pattern is routinely seen in generalized anxiety. True fragmentation generates completely independent, miniature sleep events. The brain executes perfectly formed, completed microcycles of NREM and REM sleep. These completed microcycles are separated by 15 to 20 minutes of total lucid wakefulness before the next cycle arbitrarily begins. The most extreme degradation is complete desynchronization. The 24-hour temporal structure is entirely destroyed, leaving chaotic blocks of NREM and REM sleep scattered randomly across the day and night. This specific state is strictly associated with severe neurodegenerative diseases and brain tumors physically destroying the master clock. The total loss of temporal sleep structure provides an immediate physiological signature of organic brain failure. This chart acts as a diagnostic matrix, synthesizing our three clinical vectors: continuity, architecture, and circadian rhythm. Tracing these specific visual signatures on the hypnogram accurately identifies whether the root cause is somatic, psychiatric, or neurological. Treating secondary insomnia with blanket prescriptions for hypnotics or generic sleep hygiene routines guarantees clinical failure. Symptom suppression ignores the lesion. Without root cause identification, the underlying disease advances entirely unhindered. Therapeutic efficacy requires mitigating the primary neurological or psychiatric pathology rather than chemically forcing a waking brain into an unnatural sleep state. The hypnogram and the circadian clock are continuous, real-time diagnostic compasses. Secondary insomnia serves as the brain's physiological distress signal, identifying the precise location and nature of the primary pathology.